I'm going to talk about, I think you might have heard about it already as I asked questions of the panelists, and it's around health disparities and inequalities in the context of sepsis incidence and outcomes. And within UK HSA, and also nationally in the context of antimicrobial resistance, which is where I mainly sit and focus attention. Since 2019, pre-COVID, we started thinking about what are the health inequalities implications for resistant infections, particularly, or infections. And pre-COVID, the answer I got was, there are no inequalities, we don't know, there's no data. Then obviously COVID hit, and then the data became available. So in many ways, that's helped. And we did quite a lot of work within our teams, particularly with the scientists who didn't think that they had a role because they thought all of the work was with those doing the interventions, so the healthcare professionals. I'm a pharmacist, the doctors and nurses who were those who were seeing the patients. But through some work and through engagement and really education, we helped them see that actually as scientists and epidemiologists, they have a key role. And I'm so delighted that actually now we don't have to encourage, they are doing so much around data to help us understand, to identify where there are challenges. We don't do it for the sake of doing it, we do it because actually if we don't know, then we can't take action. And so all of what we do is to really to be able to identify where the challenges are. We can't solve the problem in UK HSA because actually we are a public health institute, within our team we're mainly focused on surveillance and data. But what we hope is that through that work and sharing, that others will be able to at least identify that within their work and to have interventions. Because at the end of the day, these are patients, and these are our mothers, our fathers, us, you know, and the inequalities is across a breadth of inequalities. It's not just ethnicity, it's not just deprivation. Health learning disabilities is another one as well that we've been picking up. So, in my day role, I'm lead pharmacist for AMR HCAI. I'm also honorary chair and professor of pharmaceutical public health at the University of Nottingham, and I'm deputy chief scientist at the Royal Pharmaceutical Society. What I'm going to focus on is on the main majority of my talk is about this paper that we did with colleagues at the University of Manchester. So when the Academy of Medical Royal College's statement was published, we really wanted to understand if there were any health inequalities in the context of sepsis in the UK, in England, which is where our main focus is. So we wanted to do a systematic review. I'll share some of the overall data. So, and then colleagues in Manchester also had access to Open Safely data, and so they were able to help us to look at the data and to analyze it. So we had data for England, and that's where I'm going to be mainly focusing my attention. And you can see there that there's a lot of people who are involved in this. I'm really grateful to them for that. I have a range of affiliations, which I've already mentioned, one of them being another part of work that I'll talk about later is being funded through NIHR, and is focused on resistant infections and bloodstream infections. So this has been talked about a lot, and actually I'm just going to move on. But one of the things I wanted to highlight is what we knew previously was that there was disparities mainly from the US because they had been publishing data, and we didn't really have information for England or within the UK. And also we've talked about the average cost of sepsis per patient in the US being $32,000 based on our analysis then. This is how NHS England frames how we can tackle health inequalities. Because again, sometimes we think there's nothing we can do. What can I possibly do? Where do I start from? But there is a Core 20 Plus, which NHS England uses, and it's a way to highlight where, if you are thinking, where would I focus my attention? Where do I start from? These are the groups that have been identified as most likely to have those health inequality factors. So Core 20 being the most deprived 20% of the national population, and identified by index of multiple deprivation. Plus are the inclusion health groups. So, for example, those who are underserved, we call them underserved. So, sex workers, people in contact with criminal justice system. This got off my head now. High risk settings as well. So there are a range of inclusion health groups, and you'll see some of them come up shortly now. And then there's some clinical areas that have also been identified. So maternity, so we know that particular groups are more likely to die from maternal sepsis, severe mental illness, chronic respiratory disease, early cancer diagnosis, hypertension finding. So these are the clinical areas where inequalities have already been identified, and they want to focus attention there. And then smoking cessation, the fact that if we can actually have a core action that it will underpin and support all of those areas. So what did we do? We did a review looking at data, looking at published information from 2010 to 2023, and looking at inequalities in sepsis. As we thought would be the case, most of the data came from the US, and there was hardly any data from across Europe at that point. But the key points were around socioeconomic factors, ethnicity, geography, care, and geography, so rural versus urban, for example, and then care settings was one of those. And then the findings was, as I said, scarcity of studies, fragmented evidence, and then impact of disparity on sepsis recognition and treatment was identified as a gap. So in terms of COVID, obviously, we know the impacts we had through COVID, the indirect effects in terms of changes to other diseases due to lockdowns and social restrictions, altered healthcare access. And then our focus was really to look at non-COVID sepsis, but looking at it pre, during, and after the COVID. So our study was to look at the changes in non-COVID sepsis rates during the pandemic, because that was the time when we were doing this in around 2022, 2023. I wanted to explore if there were any links between socioeconomic status and sepsis outcomes, and then also to look at clinical factors. So not just, we knew about there might be something around the inequalities, but what other clinical factors were there that affect sepsis and mortality rates? We're also trying to think about what are the modifiable risk factors, because sometimes you can feel that because we're healthcare professionals, most of us, and when you hear about a lot of the inequality factors, they are systemic challenges. We can't impact on housing. We can't, we don't, as a nurse, we can't necessarily change someone's housing, but we can flag it and we can support them. So what are those that are within our own gift? So we used Open Safely data. It's a platform which pulls in data from primary care, particularly TPP. So there are two main systems within the general practice. TPP is one, IMIS is another one, and that covers almost 90 to 95% of the England population. We then were able to link the data to Office of National Statistics, ONS data, second generation surveillance system, which I think Jocelyn mentioned earlier, which is where it's our microbiology data, national microbiology data, and then secondary uses services. I said we. This was all done by a PhD student who does all the data analysis. I'm only learning more about data analysis these days. I've gone back to do some of that. The analysis period was 2019 to 2022, and then identify the sepsis through the ICD-10 codes, which Jocelyn mentioned earlier. We did that at that point. Obviously, we're now going to work with Jocelyn to make sure that we pull in all the ICD-10 codes properly, and then looked at the new sepsis cases. We excluded anyone that had been in the primary care registration for that general practice for less than a year, and then anywhere where there was missing indices of multiple deprivation in region. For colleagues, indices IMD is basically a way in which we put different areas within the country into levels of deprivation. There are limitations with that, because you can have an area that is very affluent and it's low deprivation, but actually you can have strong pockets of deprivation in there. So there are limitations. And then we did a case control study. So for every patient that had sepsis, we matched them to 6 others that didn't, and we matched based on age, sex, and calendar month. So in terms of the study outcomes and exposure analysis, we were looking for both community-acquired and hospital-acquired sepsis, and we're also looking at the 30-day mortality post-sepsis diagnosis, and the exposures we're looking at was IMD, which I talked about, demographics, and then clinical factors. And then in terms of the analysis, if those were particularly interested, logistic regression and crude and fully adjusted. And then we looked at the missing data approach as well to make sure that the missing data was not going to impact on our results negatively. So the number of sepsis cases that were identified was 224,360. And you can see that the majority were community-acquired sepsis, and about 40,000 of them died within 30 days, and then hospital-acquired sepsis were 44,000, and 7,000 died within 30 days. This graph here, I think what I just want to show you here is to see the differences between the most deprived and the least deprived. Least deprived is 5, so the light blue, and then the purple is the most deprived areas. So that's how we classify them. They're in quintiles, so in 20% grouping. And you can see there that there's a difference between those in the most deprived groups and those in the least deprived groups. And then we also then, and this is a good way to look at the data, you can then see where there are major differences in the data across a range of factors associated with health inequalities. So deprivation is one, you can see the IMD1, so most deprived. And then in terms of ethnicity, it was South Asian, and then those who are classified as other. There are challenges in the way in which people are, their ethnicity is coded, we know that. And then those who are underweight, and then those who are obese. So coming back to the fact that there are challenges within sepsis, and there are different factors which may impact on people's incidence of sepsis and also the outcome of their sepsis. And then smoking as well, both former and current. And then where people live as well, so we identify those who are potentially in care homes as a way in which you can code for that. Again, you can see that there's a big difference there. And then also those who have got chronic kidney disease. And then those who have got diabetes that is not controlled. So here we were able to identify not only just the health inequality factors, but also clinical factors that can impact on incidence of sepsis, as well as the ultimate outcome of what happens with the patients. And then also cancer, so non-hematological cancer, but also hematological malignancy, chronic liver disease, other neurological disease, immunosuppressive condition, and learning disability. For us, when we went into this, we were thinking health inequality factors alone, but you can see there that there are a range of factors that may impact on what happens in terms of incidence of sepsis, and also the outcome for the patients. And then also those who have had 3 or more antibiotics in the previous year are also more likely to have sepsis. And that may make sense because they're obviously going back and forth, and it's not. And that could be that they didn't get the appropriate antibiotics in the first instance, or there might be a whole range of things, or they're having repeated antibiotics and have resistant infections, which then means it's not the infection is not clearing. So just very quickly to wrap up here, and I'll move on to another section very quickly. We know that socioeconomic deprivation and various clinical morbidities are associated with non-COVID sepsis risk. We've identified the high-risk conditions, and they're listed there, including learning disability, immunosuppressive conditions, chronic liver disease. We know that sepsis incidence did dip during the pandemic, but it's rebounded post-April 2021. And so again, we're back to those pre-pandemic levels. I think it is important, and I am flagging this, and I am getting on a soapbox about it, that we do need to think about it as well. And as we do for other areas of health as well. That we do know that, though, having that information is not enough. So what we're now trying to work out is what are the modifiable risk factors, what are the potential interventions that can actually be put in place to support those on the front line who are seeing these patients. This infographic is, we published it in our SBAR report, so that's the English Surveillance Program for Antimicrobial Utilization and Resistance, just puts a summary of all the various factors that we've talked about, the clinical factors, health inequality factors, and then sepsis incidence and outcomes. So it's a summary of some of what I've highlighted there earlier. We also did another piece of work using a CPRD, which is another general practice data set, and within that we saw frailty as another, those who've got high frailty score, where also is another risk factor for that. Interestingly, patients, so for that CPRD one, which is focused on the older age group, patients with non-white ethnicity did not show an increased sepsis incidence specifically. So it's not always that ethnicity is an issue in terms of all areas, and that was one of the things in terms of sepsis for this particular data set that was looked at then. I talked about the importance of where do we go next. So we really need to identify what are the risk factors, and then which of them are modifiable so that we can develop an intervention. So the next phase for where we're going now is to look at those look at those risk factors, and we're doing another systematic review which has got 16,000 papers to look through. So if anyone's interested in participating in the systematic review, let us know. We've got to screen 16,000 papers to try and understand, and we're focusing that on antibiotic resistant bloodstream infections among socioeconomically deprived groups in high income countries. Nationally, though, and Jocelyn highlighted this very quickly, is we do have the National Action Plan, which focuses on antimicrobial resistance. And Jocelyn's already highlighted that within that National Action Plan, there's quite a few particular deliverables and commitments which focus on understanding infection burden and sepsis. But we also then have those that focus on tackling health inequalities, particularly there. So that's the public engagement, surveillance, and then there's a full outcome on health disparities and inequalities. So looking at data on health inequalities, toolkits for health inequalities, and then interventions to reduce health inequalities. And the process for developing that was using for the health inequalities one in particular, because that's the focus of my talk in the context of sepsis, was a Delphia process with 100 professionals across clinical, policy, and data and epidemiologists across all the 4 UK nations, and then also getting feedback from our governance groups. So what do we have in the National Action Plan to tackle antimicrobial resistance? We have around making sure we have good data. So that's part of what Justin was talking about earlier. So making sure we've collected good pathways for collecting and reporting on data on infection incidents. And that obviously some of that will include sepsis incidents, antimicrobial use, but also across those factors commonly associated with health inequalities, but also age, sex, disability, deprivation, geography, high-risk settings such as care homes. And you can see there that in some of our data, we're already reporting therefore antimicrobial resistance and antimicrobial consumption. And we need to, and that surveillance that has been talked about, so where do we fit in the sepsis one, and where do we report that? There was another a commitment, which is around having cost-effective, evidence-based resources that is adaptable to local needs, and we've started to look at what's there. Again, there's a gap in terms of how, you know, I've highlighted today that we know there's health inequalities considerations for sepsis, and then I guess the question you would ask me is, so what do I do about it? And so we know there's a gap in trying to pull together that information, so we're trying to do a review, and then we'll pull together toolkits using a consensus approach with colleagues. There's also one inclusion health groups. Looking across all the inclusion health groups, what are the interventions already in place, and what are the levels of infections, resistance to infections, and then also antimicrobial use across those various inclusion health groups. And we're looking at, we've already completed for those in contact with criminal justice system, for those for sex workers. Adult social care is not an inclusion health group, but it's a high-risk setting. The other one that we're working on at the moment is those who inject drugs as well. That's another one of the inclusion health groups. And then an engagement guide. How do we engage with the members of the public so that they are aware of the risks, and then what can they do to mitigate those risks? And many of you may have heard of the antibiotic awareness campaign that we have, but we also need to think beyond how do we prevent infections in the first instance as well. So if you are interested in helping us develop any of the health inequalities toolkit, or also in particularly around health inequalities or sepsis, or any of the work that either Jocelyn and I have talked about today from UKHC, please do feel free to scan that QR code and add your details to that, and it'll be one way in which we can keep in touch with you and be able to get you to contribute to the development of the national toolkit as we get to it. I'm going to stop there. Thank you very much.